So I want to start out by thanking our two initial speakers. I think that both of the speakers shared with us unique kind of activities out there. My name is Jan Berger, and I am the CEO of Health Intelligence Partners, which is a healthcare consulting company, just to give you a little bit of background. And for those of you who may not remember, this session is called Addressing the Challenges in Diabetes. And so what we've done is we have brought a variety of stakeholders together. From the far end, Amy, who probably has more skin in the game than anybody at this table, as Amy is a person who has type 1 diabetes. And so we often don't remember to ask the person who lives and breathes it every day. Amy is a wonderful spokesperson for that in regards to this. Maria is representing the managed care world today, although she has had a variety of jobs in her career. But she will be talking about the few, representing the few of you all out there who day in and day out, whether it's through pharmacy benefit, mental health benefit, or the managed care world, what their role is. Josh, as you've heard, is a pharmacist, although he's not wearing his pharmacist hat today. He is wearing a researcher and an entrepreneur in a solution and helping us deal with this. And then Nadia, as a researcher in the area of cultural diversity at the table. I want to start out by asking the four of you, from your viewpoint as you sit today, and you only get one, so no cheating with the second, what do you believe is the greatest challenge that we have in addressing diabetes? And I'm leaving addressing as a very vague question, statement. So Amy, we haven't heard from you yet, and I think we have to do a little level setting here. So I know you're not shy, so can we start out with you?
Okay, but I love that when these panels start out with, what's the biggest problem in the world? That's a huge question that you're asking.
Absolutely.
And by the way, I want to point out that I am not just a patient, and I sort of take issue with putting people in the box of either you're a patient or you're something else. I think it's incredibly important to remember that every single patient out there has a professional life, has a family, travels, deals with the holidays, does all of the type of things that you guys, if you think about what you did in the past 3 days, and then you think about doing that with diabetes, and that you're supposed to take your meds on time, in the case of me, wear these devices attached to my body and be extra careful about what I eat and be extra careful about how I exercise and be this superhuman, super healthy person, it's a huge challenge. So I just, in an era of sort of authenticity and transparency, I would say it's incredibly important to keep that in mind. I run my own program for diabetes innovation at Stanford University. I run a site called diabetesmind.com, which is one of the leading sort of patient-led newspapers for people living with this illness. I mostly play in the world of type 1, which is obviously a kind of parallel universe. But I would say that, to me, that is the biggest challenge, is that I think that there's sort of this breakdown in recognition of what the reality is of living with a chronic illness like diabetes. And I think that if there were permeated throughout pharma industry, throughout payers, providers, a better understanding of what that is actually like, that we would have better solutions today.
I think that's a really good point. And the group was sitting and talking prior to starting the conference today around trying to eat healthy and traveling and going through airports or sitting on airplanes and eating healthy. And Amy reminded us, not only is there a challenge in eating healthy, so someone can go and give her, well, you can eat all this fruit, it's healthy. And she's like, not so much. So I think that your point of living as normal a life as you can and all the challenges and then just piling on, if you will, with this is a very important lesson for all of us and not one that most of us remember. Maria, You've held several managed care jobs in your life. Please share with us, as you think of the number one challenge sitting in your stakeholder spot, what is it?
Yeah, I think one thing that...
Can you, yeah, there we go. Thanks. So everyone can hear you.
So health plans typically have a lot of data. Health plans also have usually resources, whether it's care management, disease management, case management. Doesn't almost doesn't matter what you call it. But there's a lot of interaction, or an attempt to interact with members. And this could be outpatient. This could be at the time where patients are transitioning from inpatient to outpatient. But there are resources that health plans have in an effort to outreach to patients. And the goal is always to hopefully think about, from a patient-centered approach, how not to duplicate efforts. Because a lot of people may be calling, but we may be calling and asking the same questions. And in the end, the patient needs help, right? So I really like what the two speakers were about, because probably the biggest challenge a payer thinks about is the patient engagement and the provider engagement, frankly. And on the patient side, it's trying, how do you make it scalable? How do you individualize that degree of scalability? Payers don't also have endless resources, right? So I can't go to a CFO and say, oh, I need more 100 case managers to be able to do a better job. Because the bottom line is we all have constrained resources, and we have to figure out how do we do it better. And one solution does not fit all patients in terms of what's going to work. On the provider side, we also have a lot of data, a lot of capabilities to do physician profiling, a lot of capabilities to sit across from providers and tell them exactly how much money is left on the table from a quality perspective. I love Josh's talk, because it really spoke to what it motivates payers. And you talk about HEDIS and Medicare stars. And one star, if you go from a 4 to 5, is worth about $55 per member per month. You talk about a 40,000 member plan or a 100,000 member plan, huge dollars. So there's a lot of dollars riding on the health plan to do that improvement, and for physicians as well. But the bottom line is physicians then turn to the plan and say, help me. And the focused list, the real-time data, and then also the resources. How do you then work with that practice in terms of having care management be a central part of that office practice to help with the infrastructure that office may frankly not have? In a patient-centered medical home, you literally turn things upside down, and you have that level of integration. The physician still has 5 minutes to spend with a patient. But then the bottom line is there's a lot of outbound calls, the behavioral interview and the motivational interviewing. What makes patients change, and what do they need to change? And it's not a phone call. It's certainly not a newsletter. And when you hang up the phone with that patient, maybe other 5 phone calls have to take place to actually fix the problem. That starts with understanding at the patient level what's driving non-adherence. It's not always cost. But the nuances in terms of how do you motivate that individual, and also who do you focus on? Because there's certain, when you take a strategic approach to where you can move adherence, sometimes it's really, you can't give up on your sort of bottom tail members. But if they're so far remote from wanting to change, you can devote all the resources in the world, but you're not going to make a difference. The key is to, when you think about population-based management, to think about who can you intervene on that hopefully is going to make a difference to your stars, and also make a difference to the provider group that's managing that patient, frankly, does not have the tools or know what to do next. And it may also be for naught, because if others are calling, wouldn't it be nice for that practice to also know that? And so in a partnership or shared voice, be able to, I guess work collaboratively is the right answer, but know also when to bring a patient into the office. Many providers have no idea what the adherence is. They don't even know if it's an efficacy problem or an adherence problem. So they just pile on more drugs without even knowing what conversations to have.
Josh, you get one challenge here.
I think there's going to be a theme here. because this is going to sound pretty consistent, but I think our biggest challenge, and it's not unique to diabetes, by the way. Can I just say I think this is the biggest challenge in healthcare for the 21st century is how do we improve the health of a population while being patient-centered or personalized in our approach? Because the past 2 decades of old-style disease management have proven to us that you just can't blast a population with a one-size-fits-all intervention and expect your problems to go away, your health status to improve. And so this will be the era, I think, of personalizing our approach to population health improvement, and I hope we can do it.
So definitely a theme. I mean, I would say the biggest challenge is the changing demographic in the U.S., and that's not just demographically in terms of race and ethnicity, but also social factors, in terms of increasing poverty rates, the changing nature of the workforce, thinking about racial and ethnic minority groups. MI, motivational interviewing, it's a great tool. Is it going to work if a phone call is using MI that's not in your language, or that isn't situated in kind of the cultural context in which you come from? Probably not. And then in terms of thinking about how things are changing socially, there were some representatives here talking about DPP. DPP is a great program. It's evidence-based. It's also 16 core sessions, 22 recommended sessions. How is that going to work for people in the workforce who are working, 6 to 7 days a week, 12 to 16 hours a day? I know there's a movement towards integrating DPP into the workplace, work site-based health promotion. It's a great idea, and it may work very well in office settings or corporate settings, but is it going to work for independent contractors, for small business owners, et cetera? So I'd say those are the challenges we have to confront.
It's interesting. I've been very lucky that I have, over the last 5 years, taken a number of senior healthcare executives to other countries to learn about their healthcare systems and what works and what doesn't work. And it's great. The good news is, I'm going to start with the bad news, in fact. The bad news is I've been to 11 countries, and when you ask in those 11 countries what is their biggest challenge in healthcare, every single one of them, from Israel to Cuba to France to Australia, I don't care where you are, I don't care how healthy you are, every single one of them said diabetes. That's the bad news. The good news is, when everybody is struggling with the same problem, my hope is that maybe we can work together and come up with some unique things. One of the things I want to ask you, Amy, is in part of your day job is innovation. Where are you seeing some of the innovation? What are you seeing, maybe something that works or is promising? But then what I want to ask you is, how are you seeing the different stakeholders here? Because there are so many stakeholders involved, and you need aligned goals. How are you seeing that play out? And as you do that, I then want to have each of your co-panelists maybe respond to what you are saying here and not just to my questions.
Sure, okay. So I definitely, I agree with what everyone said. I think that there's a lot of focus on the idea that patients need education, which they do, and that they need sort of high-touch, sort of mentoring or coaching programs, which they do. But I think that the challenge, the core challenge with an illness like diabetes is that, remember, this is for life, right? This is not going away. And when I look ahead, I've had diabetes for 10 years now, and I don't hardly know anyone with type 1 who's an adult who hasn't experienced clinical depression. It's an extremely difficult thing to stay motivated, and I think what we all lack is some sense of accomplishment. So we did our own study about people's attitudes towards diabetes technology, the tools that they're getting their hands on, and asked about 800 patients, some of the most engaged people online, what would motivate you most to get more engaged in your own care? And we were shocked that the top answer by a margin was simple, positive feedback from some provider or someone helping them over time. I think people feel that, they're being punished with this illness, and we talk about programs that incentivize providers. That's great, but there needs to be some reward or some sense of accomplishment that the patient can have over time. Otherwise, it's incredibly difficult to keep this up. And you might do an intervention program that brings up the numbers, and you think, wow, that's amazing, but in 2, 3 years, 4 years, 5 years, where are these people going to be? Because they can't have their hand held all the time. So I think we need to build that into our system. And so I think some of the innovations that I've seen that I think are most exciting are trying to go in that direction. So what we do at the Diabetes Mind Innovation Summit is it's very technology focused, actually, but we've sort of spread a little bit because it sort of started out as how do we design products that actually accomplish something of value for patients and involve them from the very beginning in the conceptualization of these tools. So we brought in pharma companies, probably all 13 of the top pharma companies that create products for patients with type 1 diabetes, and then a lot of technology entrepreneurs in Silicon Valley who are creating all these mobile apps, of which there are about 1,200 now for diabetes, and about 1.2% of patients by a recent study actually use them. I mean, it's really pathetic because they're not designed to provide any true value. All it does is add another layer of work to having this illness. So again, it needs to be easy. There needs to be something to motivate you. I've been hearing about some new programs that do kind of combine a coaching approach and also helping patients make use of that data that they're spending all this time collecting and logging and make sense out of it. Otherwise, it's, again, just another burden for both the provider and the patient. And everyone seems to think that that's sort of the holy grail, that diabetics can gather up all this glucose data. And then there's things like Adhere Tech. I mean, there's some things that are a little simpler that maybe are just a reminder. And, some of these programs are trying to bring in almost like a community aspect or a gaming aspect or something like rewards cards, which sounds like kind of silly on the surface, but it actually is something that motivates people, that if they can be incentivized to make sure they get their A1C every 3 months, because, it's a pain to go do it and you usually don't want the bad news, but, if there's something to motivate you. So, I'm really enjoying seeing that there's, when we talk about patient-centered, which is kind of a buzzword, that people are starting to understand that there are human beings on the other side of that who really need something to help them keep going with this.
Before you give up the microphone, I want you to share. We were all sitting here talking about, exercise is really good for all of us. And it's extra important in many cases to have some control over that with people with diabetes. So we were all showing our, different bands and all this. Amy, what was your response to that? Because that was fascinating to me.
Well, I just laughed. I actually have to say I have my office is just full of gadgets that I get sent because I get sent things to review. So I have like every glucose meter that's ever been made and, all of this stuff. So most recently I have a Fitbit and a Jawbone and a Misfit and all of these accelerometer products. And I asked Jan, I said, I don't wear one. Do you know why? And she just kind of looked at me funny because I'm usually the big, sort of health tech enthusiast. I said, I'm already wearing 2 sensors on my body, one of which is rather lumpy, and one of which beeps constantly. So I wear a continuous glucose monitor, and I'm wearing, thankfully, I'm happy for this innovation, a tubeless insulin pump, but nevertheless, it's this lump, and I have these controllers, and then I have an app that, several apps on my iPhone, some of which interact. I said, the last thing I need is another gadget that, unless it's going to really sort of make things easier, it's going to be, like that big, don't they have the universal remote for the TV?
Yeah.
That's what I would need.
And again, I think it reminds us of the challenges we have. So technology, how do health plans look at innovation, whether it's technology innovation or other type of innovation in the world of diabetes?
So I think health plans tend to be skeptics until shown otherwise. Let me start off with that headline. So pilots are usually a great way to test innovation. And through pilots, you certainly learn a lot. You learn about who's the patient, because right patient is really critical. You can have technology, you can send out IVR calls, you can have telehealth services. But if that's not the right patient, doesn't matter, because they're not going to respond. They don't want to get the calls. They don't want to interact. So the key is really to figure out back to you have a problem and what is the right approach or what is the right solution that's really going to assist that member in the end and help them stay motivated, stay connected. I think, plans like to see outcomes. They like to see results. They like to connect. In the short term, it's going to be about quality measures, because in the short term, that's what you can deliver. 3 months, you can see whether the A1C is moving in the right direction, the BMI is moving in the right direction. What is that impact ultimately on Medicare stars, which is huge. In the long term, hopefully you can get to outcomes. You can get to events. You can get to hospitalizations and readmissions. But that's probably going to take 18 months. And for some disease states, perhaps even longer. So I think there's a huge role for innovation. We have to get beyond where we are today. We're not winning the battle. We're not, we're spending a lot of dollars on patients who are diabetic, who are not at goal, who are on multiple drugs, and still not at goal. So I think the evolution of clinical pathways that frankly are going to help physicians understand perhaps what is most appropriate for patients to start off on. Again, individualizing patient needs, but also hopefully overcoming some clinical inertia, because the clock is ticking, the health plans are reliable for quality measures, and the physicians are also accountable for those same metrics. I also think that in terms of innovation, it is not a one-size-fits-all. Sometimes technology is a great tool for some, but it's usually thought of, particularly in the Geisinger world, it's really thought of as an extension of care management, not as a substitute. And I think we have to still keep that in mind. And for some patients, you really do have to keep the high touch. And there, a pharmacist, PharmDs, in terms of the outreach, really can enhance what happens and the understanding of what's happening to motivate that patient. And it's also not one phone call. It's usually a lot of different things that have to come together. The final piece is more is not better. I couldn't agree more. More technology you sometimes have in the home. The alarms are going off. What kind of information are you sending that to the clinician? Because you want efficiency, not less efficiency. You want more efficiency. So this concept of what's clinically meaningful but also actionable to allow patients to win and providers to win is critical. Because again, somebody's paying for this. And unless we really figure out what is the solution that's really working, and in the end, connecting the dots in terms of what do the outcomes look like? Is it moving the bar? What else do patients need in terms of support? Connecting that also to the health plan, because again, they're health coaches, they're care managers. Again, we have to think in terms of more of holistic and team approach so that in the end, we are moving the bar for patients and also for the system.
Same question, Your Honor.
Yes, sir.
I think 2 areas of innovation are really exciting right now. One is payment, and changing what we pay for and how we pay for it. 5 years ago, we didn't live in this star ratings world where plans were investing the hundreds of millions of dollars that are being invested in improving those measures today. And by the way, it's a cautionary tale, right? Be careful what you provide incentives for, because those measures will move. And so that innovation around payment, there's going to be stuff that has unintended consequences. We're going to reveal that we're not necessarily paying for all the right measures, and we need to add to those measures. We need to strengthen the incentives. We're learning now whether paying payers incentives works better or less better than paying providers directly to manage numbers. And so I think that's all very exciting. I think we have a ton to learn there. And that leads me to the second area, which is information technology and analytics that go with it. Obviously in that space, but we have more and more information in digital format thanks to electronic medical records, care management data, and administrative payer data. We can now track people, their individual journeys through the system. And I think that can only help move us in the direction of providing better care for people instead of just managing diseases. And I think that's the goal. And if we keep focused on that goal, then advances in IT and analytics are going to help us get there. And one way they're going to help us do it is by measuring the impacts of all these innovations that we're trying, whether they're payment or otherwise.
You get the last word, because we are standing in between this group and their cocktails.
So I better say something good, huh? I mean, I think I'm going to take a slightly different stance from some of the other panelists and just say that I think in terms of innovation will have to go beyond technology innovation. If we want to make an impact in terms of diabetes care with the population where diabetes is increasingly going to be concentrated, which is the immigrant population coming from other countries here, I just want to share an example that's from a slightly different area, but I think speaks to my point. One of the other hats some of our CHWs wear is being part of the health exchange, helping to enroll communities onto the health exchange in collaboration with the state. And in their outreach to the communities, the number one thing they learned is that the majority of folks don't know anything about the health exchange, which seems astounding. It seems unbelievable, right? In this day of information, we have so much information so easily accessible. How do folks not know anything at all about the health exchange? But I just think it's a good example of how we're not as sort of connected, and not everyone is as connected and has access to information in the same way, that we think about it. So I think innovation has to occur in terms of thinking about innovation in terms of the workforce, changing who we think of as part of healthcare teams and healthcare systems. So I'll just end with that.
So as the moderator's prerogative, I'm going to take the last word. And for those of you who know me, that's not unusual. At home, I try to get the last word as well. Both when I look at the challenge and the innovative opportunity, I also am going to look a little differently. And that is, I actually think our largest challenge is the fragmentation and the segmentation of the people who are involved in both the problem and the solution, and the lack of trust. I've been doing a lot of work recently on trust, and I love meetings like this because you saw we're a very multi-stakeholder group here. And some of the innovation is us getting together and opening up our minds and starting to learn what we each think and how maybe we look at these things a little bit differently, and maybe that's how we get the next innovation that works a little bit more. So I think our challenge is trust, our opportunity is talking and learning from each other, because we know that, patients and community workers and, I hate the word patient, people with medical problems don't trust the healthcare system. And we heard that especially in certain ethnicities. But if we all sit down and talk, we all learn maybe we've got more in common than we do different. And so I think as we go through, this evening and tomorrow, listening and learning and asking each other, and then maybe coming back at the end and thinking about these same questions and see if we look at the world a little differently.